So I remember the first time I personally witnessed simulation in action. It was 2013, and I was a visitor to Harvard Medical School's Med Science program. And this unique program uses hands-on simulation to teach high school students biology in order to promote STEM careers. And while observing the high schoolers doing their med science demonstration, I remember feeling shocked how real it felt, the level of engagement, and how calmly and effectively this group of 16, 17-year-olds triaged and stabilized an otherwise undifferentiated patient. And I have since made it a personal and professional goal to improve access to this type of technology and pedagogy, along with the rest of the CTLT team here at UGHE. I'm very excited to share this experience with you today. So just to set the stage a little bit, during today's case, you will see members of our team playing a number of different roles, which I will touch on in my closing remarks. Our learners, who will be playing second-year medical students, have already been introduced to the equipment and expectations of the case, but do not know all the details of the patient's script. We will run through a live simulation for about 12 minutes, and afterward we will conduct a short debrief in character before breaking the scene. So I also want to inform you that everything you're about to see is controlled and simulated, and as such, there is no need for any alarm. So, without further ado, I look forward to introducing you to our amazing team of UGHE simulation faculty.
Help, someone help me, please.
Oh, can we get some help for this woman? Do we have any medical professionals in the audience? Yeah, can you please help this woman?
Oh, I don't know what's happening. Oh, Jesus, I hope it will be okay. Oh.
Hello, ma'am. We are a team of medical students from the University of Global Health Equity. We are going to take care of your child. Please bear with us. Hello, team. So I will be leading the session, doing airway, breathing, and a circulation assessment. Kelly, you will be taking history and getting us more information from the mother. And Becca, you will be taking vital signs and monitoring the child. Okay, can you get started?
Hello, Mama. Please.
I'm doing airway assessment. The airway is clear
I'm worried.
and open. I'm now progressing to assessment of the breathing. Can I get stethoscope? So on inspection, I can see the child is having nasal flaring. The child has usage of accessory muscles, and there are intercostal and subcostal retractions, severe retractions. And the child seems cyanotic. Let's monitor the vital signs.
Olana, the saturation is 70%.
The patient is desaturating severely, so we will have to put him on oxygen, and he gets nasal cannula 2 liters.
Doctor, what's happening? Can someone tell me?
Just calm down.
We have supported the baby with 2 liters of oxygen with nasal cannula. We'll see the progress. As we support the kid with oxygen, I check the circulation. It seems the baby is dehydrated. I can see dry buccal mucosa, and it seems capillary refill is also 3 seconds.
And look at that blood pressure. I think it's too low.
Yeah, so we will check on chart. This seems young.
Fluid.
Okay.
How much?
So can we give him a bolus for now,
Okay.
based on the weight of the child?
Doctor, what's happening? Can someone please talk to me?
Can you tell me the weight of the baby?
I
Please.
don't remember, 15 or 14 kilograms. I don't remember what. What are you doing, doctor? Is he going to be okay?
Okay, so we are supporting the kid with oxygen. We gave intravenous fluid. Now we will reassess. In the meantime, Kelly, can you get us more information about what happened to the child?
Hello, Mama.
Hi, doctor.
My name is Kelly. I'm a medical student, and we are trying to help your baby, but we need you to help us also.
Becca, in the
Give us
meantime, you
some
can
history
do
of the baby, okay?
focused
What do you want to
physical
know?
exam.
Okay, how old is
He's 8 months.
he? And you said he's having 8 kg or 12.
No, 14 or 15, I don't remember.
Okay, what happened?
He was struggling to breathe, and since this morning he was having some noisy breathing.
Okay.
But I'm really worried. Is he going to be okay?
We are going to try our best to help him, okay? So tell me, did it start this morning or before it started like 2 days ago, 3 or 5?
I think it started like 3 days ago.
Was he breathing like he was today or?
No, it was not that serious, but he was having some
Runny nose?
Yeah.
What about coughing?
I think he was coughing.
What about fever?
No fever.
Are you breastfeeding him?
Doctor, why are you asking me so many questions? Can you please
Yes,
help me
your
get my
answers
baby?
will help us. Can you tell me?
Yes, I'm breastfeeding
Okay,
him.
thank you.
Yeah.
Did he vomit or anything?
No.
The pregnancy went well for him?
Everything, yeah, doctor.
Everything was good?
Yes,
Okay,
everything
thank
was
you.
fine.
I will come back and ask you other questions, okay?
What's happening? Was he poisoned? I'm worried.
No, we are going to check and tell you. Do you have any other problem in the family like asthma or any chronic condition?
Yeah, his dad suffered from asthma.
His dad?
Yeah.
Okay, thank you.
So let's think about the case. So you will tell us the summary of the history and your summary of physical exam. In the meantime, it seems the saturation hasn't improved yet. We put him on oxygen, but it's still 82. Can we get face mask?
But shouldn't we just go up, like 4 liters nasal cannula?
So with nasal cannula, it can be tricky. So what do you think? If we get face mask, give 10 liter, 15 liter oxygen. Okay.
So he's an 8-month-old boy with 14 kg. It started like 4 days ago with cough and runny nose and no fever, no vomiting, and there is a history of asthma in the family. There is no other relevant history.
Okay, the baby is crying. Okay, what do we have on physical exam so far?
On physical exam, I heard crackles. I think they were everywhere, but maybe you should check for a murmur, because I thought maybe there's a murmur in, I don't know, like here, but I'm not sure. So maybe double check, but there's no liver that I felt, and he has no conjunctival pallor and no sclerolicterus.
Okay.
Doctor, where is that thing you put on his mouth? Is he
So
breathing okay?
That thing is the oxygen. Your baby needs oxygen to breathe well. So we are trying to do our best to help him breathing, okay?
I'm worried.
I know you are worried, but we are trying to do our best and we will tell you what's
Please.
Yes.
Okay, it seems I'm also not appreciating any murmur, so we will get more support from other people later. But so what are we thinking now? We have clinical data from history, 8 months old child presented with 3-day complaint of cough, difficulty breathing, and some noisy breathing. And on physical exam, we have desaturation, we have increased respiratory rate, we have some crepitations and signs of respiratory distress and dehydration. So what do we think is going on? What should we treat the baby for? What is our definite diagnosis?
Were there fevers?
No fever.
No fevers.
Yeah.
I still think we have to think about pneumonia.
Pneumonia, okay. In this age group, it's a possibility, we'll think of it, okay?
What about bronchiolitis? What do you think?
In these young children, bronchiolitis is very common, but the baby didn't have fever, right?
Yeah, no fever.
Okay.
What about-
It's a possibility.
Did you say there's a family history of anything?
Yeah, there's a family history of asthma.
Ooh,
You can think about it also.
yeah.
This thing is, at least we have 3 differentials now. Could it be bronchiolitis? Could it be pneumonia? Could it be asthma? It can also be some cardiac condition, we don't know.
He's desaturating again. Oh God.
Okay, now the baby is desaturating despite the oxygen support we are providing him. I think we should get consultation from a senior physician we have on call.
I think Dr. Yan is on call. Let me call her.
Should we do something before? Will you ask her what we should do?
Let me
ask her.
reassess the airway, breathing, and the circulation in the meantime.
Hello, Dr. Yan.
Hi, good morning.
Good morning, doctor. We are the emergency and we have a case. We need your consult.
We
It's
can
an
also get some
8-month-old,
labs. Can we
boy,
get,
with the history of 3 days
yes,
with cough,
CBC,
runny
chest
nose,
X-ray.
and he came this morning with respiratory distress. We put him on oxygen, high flow oxygen, but he's still desaturating. We really need your help.
We can do bag
Okay,
masking
what
in
is
the
your most
meantime.
concerning issue now?
So he's desaturating and has
Okay, let
signs
me
of-
come in. Right.
Yes, please. Thank you.
We are okay, we are bagging
So
the
tell me,
baby.
what's going on? How old is the baby?
8 months.
What do we have now? 8 months? You told me 2 days of runny nose.
Yeah,
and-
3 days of runny nose and cough, no fever, and today he desaturated and started to breathe.
Can you bag properly, my dear? Just apply the mask properly. Is the oxygen up? Yes.
At
Up.
15?
15, right? Yeah. Who want to apply well the mask and then start bagging? Yeah, should come up. can you put the stethoscope and
Okay, let's see.
here?
Oh, Jesus, is my baby going to die? What's happening?
Mama,
Where are you
So-
going?
Can you help
What
us
is
and
this?
I am appreciating
Please sit.
air
What are
entry
you
is
doing?
controlled down the fetus anteriorly and
We are
posteriorly,
trying to help
but
your
the
baby.
respiratory
Can
effort is still
Ma'am,
full.
I'm Dr. Ariane, the pediatrician on the call. So I see the baby is having respiratory distress, but no worry, we are going to manage, okay? Give us some time to understand what's going on and we'll come back to you, right?
It looks like he's...
Thank you. No, I'm
Mama,
managing.
what is it?
Yeah, can you put a stethoscope in my ears?
Please stay
Can you
with
check
me.
the perfusion on both limbs?
Okay.
Okay.
We've already given a bolus, and
Actually having clear, good air entry, but bilateral crackles.
Yeah.
It's like, yeah, he must be not ventilating well. Did you send any labs like blood gas?
So far, we have sent
Can you tell us?
complete blood count. We have sent arterial blood gas analysis and the chest X-ray. So the findings are suggestive of acidotic for ABG, respiratory acidosis for ABG, and the CBC is normal.
Yeah, what do you mean by respiratory acidosis? Do we have the CO2?
Yes. The labs are, the details are pending. Yes. So the pH is 7.35.
I think we need to intubate. What do you think, Dr. Ariane?
I think I need more. Do we have a CPAP around? If we don't have a CPAP around, I will go for intubation. We have a clear.
Seems we don't have CPAP.
Yeah. Okay. Can you prepare intubation? I need a tube. Number 3 will be fine. And
I have a lot of medicines. I don't know which one.
Yeah. Give me, the propofol and fentanyl will be fine for me. What's the weight again?
14. She's not sure, but it's around 14.
So in the meantime, Kelly will inform the mom what we've been doing so far. Yeah.
And probably after telling the mom, call me the PICU so that we send the baby there after intubation. Yes, doctor. Okay.
So,
Can you give me
Your baby's not doing well.
Pause.
Okay.
That's going to be the end of our scene. I'm going to ask our learners to come over here, and we're going to sit and do a few minutes of debrief. Ornella. I think we need our mom as well. All right, give them another round of applause. That was amazing. So how did that feel?
Was stressful. Yeah, the mom was crying and agitated, and for us students, it's somehow difficult to manage that kind of level of stress. Yeah.
Yeah, what else?
Okay, I share the perspective shared by my classmate. It's a bit overwhelming. The exercise was great. Eventually, we tried to support the mom, do some interventions, but the whole experience was a bit overwhelming.
So stressful, overwhelming. What else?
I think it's hard to, kind of feel like we're getting everything done as fast as we want to. I think I wanted us to have the history and the physical and all of the examinations, and even when the faculty came in and we didn't have everything ready, I felt overwhelmed and like I was failing.
All right.
Yeah, kind of confusing. Like when coming, having a short summary, having the mom requesting for updates, and I haven't even processed what's going on, right? Kind of confusing scenario.
Yeah. So can somebody, we're gonna dive into a couple of the things maybe that could have gone better and that went really well. But can one of you maybe summarize sort of what was the facts of the case for us, so maybe we're all on the same page?
Okay, so it was an 8-month-old baby boy of 14 kg who came to the emergency room with a complaint of respiratory distress and a history of 4 days with cough, runny nose, but no fever and no vomiting, with also a history of asthma in the family. Yeah. Can you complete?
And on physical exam, we saw crackles in all the lung fields and some dehydration with a delayed capillary refill. So we started oxygen and we gave a bolus.
Great. Thank you, guys. Let's dive into a little bit of what you think went really well, that you guys did very well, or that just went well, and what maybe could have gone a little bit better.
So I think on the part of the leader, it went well. Our leader was organized and he made us be more calm, he tried at least, and our role was clearly defined, yeah.
What else?
I think also Olana did a really good ABC to start, which is something that I sometimes forget. But something that we could have tried also to add is to not forget the glucose, so ABCD, because the baby wasn't really crying at first, and so we may have missed something.
Absolutely. How about from our pediatrician? What do you think?
Yeah, I really appreciate my team of students because they managed to call the consultant right on time. And they have been doing things so far. They have given a fluid and tried to improve the saturation, even though it didn't work before I came. Yeah. You stopped me before I managed, though.
What about mom? What was your perspective?
Yeah, I think I was happy with the way the student, one of the students was put me on the side and she was talking to me and the way she kept updating me. Also the team lead, student Olana, was really managing everything and even reminding the colleague, like, please inform the mom about whatever we have done for the baby and tell her about the next step. So that was amazing, even though I was trying to be dramatic.
I noticed at one point, while one of the students was getting the history from you, the oxygen saturation was like 80, 82% for a few minutes. And so, I think it seemed to me that there might have been some distractions from you, but any thoughts from our students, sort of what was going on during that time that might have made it so that you were not able to identify that as quickly?
Well, I think it was my job to monitor the vitals, and I definitely got distracted by, the history taking and wanting to make sure I didn't miss anything. And I kind of was also just waiting to see, like, does our intervention take place? Does it happen? But then it became kind of clear that the baby was not getting any better, and we probably should have escalated that. I should have said something earlier.
Yeah, I mean, it was a very challenging case, and I think you guys all did an amazing job. So let's give them another round of applause. We're going to end our scene there. Thank you, guys. All right, well, thank you again to our amazing group of medical students and faculty. So let's just give them one more round of applause. I think that was awesome. So given Dr. Weinstock's absence today, we're going to be proceeding directly into our panel discussions after this session instead of having a keynote. So before we do that, I just want to take a few minutes to sort of meta debrief with you all about what you just saw and identify some of the core principles we applied to this simulation that you may have noticed during the demonstration. So as we discussed in the debrief, the case you just saw was a pediatric respiratory emergency where the patient initially stabilized but ultimately needed to be intubated and transferred to the ICU. So you saw the learners approach the case with a very methodical approach, ABCs, clear roles and responsibilities identified between them. You also may have noticed the different roles that me and my colleagues as faculty were playing as well. So in this scenario, Dr. Ornella Masimbi, the head of our simulation center at UGHE, was playing the role of the mother in order to both distract the learners and help steer the case in the right direction when needed. Our consultant pediatrician, Dr. Ariane, was called in for backup in order to have the students summarize and reframe the case in the middle. And other members of our team were controlling vital signs and making the patient cry and making sure the mannequin adequately responded to the learner's intervention. So shout out to our team over here and back there for making that all possible. You may have also noticed during the case itself that I was mostly silent, although I was in constant communication with the rest of the team through walkie-talkies, deciding when to transition between clinical states and ensuring that the case progressed. So when we run simulation, the amount of communication between facilitators and learners definitely can vary, depending on the level of the students, the complexity of the case, the other faculty members embedded in the scenario, and the degree of prompting needed in order to keep the case on track. So then transitioning during our debrief, you likely noticed there was a little bit of a structure to eliciting reactions at the beginning. This is what we call the emotional release, where we ask the students how it felt to run through the scenario, making sure that they had an opportunity to sort of, take a deep breath, so that we could start talking about facts and make sure that everyone felt safe in that environment. And then we make sure we level set in order to have somebody say the facts of the case, make sure we were on the same page before we started to analyze the experience a little bit more. And then the last thing you saw us do was something called plus delta. It's a debriefing technique where we started to inquire about what went well, what could have gone better during the case. And if this debrief had run longer, it would probably have become apparent there were some clinical pearls that we needed to review or knowledge gaps that made it difficult for the case to progress exactly as planned. And so we would have reviewed those and done a little bit of teaching probably to ensure that the students were better prepared next time they encountered a similar scenario. So while all this is just the tip of the iceberg, we hope you enjoyed this snapshot into our world of simulation and debriefing. And that concludes our live demonstration today. So we will now transition to our simulation panel discussions. We have two phenomenal panels for you this afternoon with experts doing inspiring work across Africa and beyond. In our first panel, we will dive into the processes of simulation center and faculty development. And then in our second panel, we will move on to a discussion about impact and return on investment in simulation education. So it is now my distinct privilege to turn the podium over to my dear friend and colleague, Dr. Ornella Masimbi, who will be moderating the first panel. Thanks.
Thank you very much, Dr. Callahan, for saving my baby and for setting the stage for today's simulation session. Ladies and gentlemen, distinguished guests, good afternoon, bon après-midi, Nilewe. My name is Ornella Masimbi. I'm a lecturer at UGHE. I also serve as the manager of the simulation center at UGHE, and I'm also a medical doctor by training. And it's my honor to serve as the moderator of the first simulation panel. As my colleague have mentioned, today we're going to discuss about simulation center development and faculty development, as the use of simulation-based medical education has increasingly become critical in the recent years in the African continent. So we need to just discuss how can we develop a center and sustain our center? How can we train our faculty effectively for them to deliver simulation? So today we are honored to be joined by 4 simulation experts from all over the world, and please join me in welcoming them to the stage. So we have Dr. Marvin Jansen. He's the head of the Clinical Skills Center at the University of Cape Town, South Africa, and he's also the founder of the African Simulation Network. We also have our dear colleague, Dr. Philomen Wibana, the Deputy Dean of the School of Nursing and Midwifery at the University of Rwanda. We have Professor Muhawi Mohamed. He's a professor of anesthesiology and critical care, the head of the emergency department at the University Hospital of Casablanca. He's also the head of the Morocco SIM. Last not the least, we have Dr. Rashmi Aradia, excuse the way I say your name. She's the Director of Impact and Healthcare Education at Laredo Global Health, India. Thank you very much. Now to set the stage of our discussion, I'd like to invite Dr. Marvin Jansen to deliver the introductory speech. The floor is yours.
Good afternoon all. It's really a privilege and an honor for me to be here this afternoon. I'm inspired by the speakers that went before me, and I do not take this opportunity lightly. Thank you to the students and the staff that did such a beautiful simulation. Before we start, I think it's important to really just provide a definition for what healthcare simulation is. And I intentionally use the word healthcare simulation because I believe that one of the important aspects is that it needs to be interprofessional. We realize that there are challenges in doing that, but it's something that we are striving towards as far as possible. So healthcare simulation is a dynamic and interactive educational approach that uses a variety of tools, techniques, and environments to replicate real-world clinical scenarios and process for the purpose of teaching, assessment, research, and system improvement. What is important to realize here, that it's not a technology, but it's a process. I believe that one of the challenges that we face in expanding simulation across the continent and across the world is the idea that often stakeholders see it as a technology. And it can be very overwhelming when you view it as a technology, because then cost becomes very prohibitive. So it's important for us to realize that it's an umbrella term that's used, but the emphasis is that it's an educational approach and not a technology. Under that technology, under that approach, there are various modalities that we can use. That could be computer-based simulation, simulated patients, simulated clinical immersion, and procedural simulation. And it even expands further in that there could be hybrids of all of these by combining these various modalities to suit the needs of your context. So I want to spend some time, and I'm going to allow adequate time for our panelists to really think about what does it mean to have effective faculty development. And one of the most important aspects, I believe, is that it needs to be contextually and culturally applicable. It's not acceptable for us to import a curriculum from a different environment and simply just implement that in our setting. There are going to be challenges. So it's important that we get the various stakeholders around the table and that we adapt our simulation curriculum to our local context. Also, we need to understand that simulation, healthcare simulation, does require significant resources. That doesn't only include costs, but that also includes manpower, etc. So when we do have these spaces in our curriculums, that we make sure that it's used appropriately. What I mean by that, we cannot have a situation where we have simulation centers or simulation spaces, but then students are coming into that space and the didactic lecture is being given in that space. I think that's an inappropriate use of that space and in that time. Also, we need to ensure that whatever we do is sustainable. Oftentimes, we find a situation where an initial funding is provided and the initial setup is done, but there's no real thought of how this is going to be sustainable for decades to come. So from the onset, we need to understand that how is this going to be sustainable? And I truly believe that the way that we can do that is through concentrating on faculty development as opposed to only concentrating on equipment and technology. Also, we need to adopt the attitude of continuous improvement, continuous quality improvement. What we do, we need to strive to be better at it with every encounter that we find ourselves in. Very important from the onset is that our simulation curriculum needs to align to the institutional goals of our context. It cannot be seen as something that is alongside. It needs to be integrated into our existing curriculum or institutional goals. Because if we do not do that, when difficult times arise, maybe there's a cut in funding, etc., if that simulation program is not integrated, it's often going to be the first time that's cut. So we need to see that whatever we do is strongly aligned to the institutional goals. Also, one of the critiques for simulation curriculum is often that our curriculum is too full. And what my response to that is that simulation affords us an opportunity to integrate our curriculum and see how we can do things differently. So it shouldn't be seen as an addition, but rather it should be seen as a way to do things differently. But most important, what I want us to never forget is at the center of this, we have to keep in mind the patient. Oftentimes, because of the fancy equipment, because of the alarms and the novelty of simulation centers, oftentimes the patient gets lost in that. So we need to understand what our context is within Africa. This is a study that was recently published that just shows what the context is within Africa. And I'll leave that up there. I would encourage you to read that paper. But it really just speaks about the challenges that we face within our context and how critical patients often have an uphill battle when they enter our healthcare system. So what am I saying is that if we want to have sustainable faculty simulation center development within the continent, there needs to be a change in the way that we view simulation. It is not a technology, it is an educational pedagogy. And when we view it from that aspect, we'll realize that the resources should not be spent primarily on equipment, but rather should be spent on faculty development. Thank you.
Thank you very much, Dr. Maravin, for a great introductory speech. Now let's dive into our discussion, and I will start with my friend and colleague, Dr. Philomen from the University of Rwanda. So Dr. Philomen, as one of the pioneers of simulation education in Rwanda, what were some of the key challenges you faced when you were integrating simulation into the nursing and midwifery curriculum at UR?
Thank you, Onela. Good afternoon, everyone. I want to share with you the challenges that we have encountered when we started with simulation back, I'll say from University of Rwanda, but even before when I was working with the former Kigali Health Institute, after we emerged in the University of Rwanda. Back then, that's when we started with the simulation. The School of Nursing and Midwifery, we used to have kind of demonstration room, and that was maybe 1-2 bed, and some little material for demonstration. So that was mainly the instructor-centered practical teaching. But then we started with the skills lab methodology. That's how we called then. That was to involve students and faculty interacting, more participatory, using some of the task training materials. And the key challenge we had then was mostly it was faculty who were not trained to facilitate clinical skills like nursing procedures using the simulation-based education. So they were not trained, and that was a challenge. I would say faculty not trained, but also when we started with training, of course, we had some, when we started introducing that, we had development partners who helped and who supported us technically. And the first thing was to get faculty on board. So there was resistance. That was something very, very challenging to have faculty engaging in simulation. And the other thing was, of course, equipment. First of all, the faculty to change the way of training from the facilitator-centered to participatory methods, and making the situation like a more or close to real situation. So we had to have also other resources engaged. So we had to get equipment. As I said before, we started with the demonstration, then we went gradually to task trainer, then to low fidelity. But the resources, of course, with limited resources. The other challenge was the adaptation of the students. Students, bringing them to be participants, like getting involved in the process of their learning, it was also something that was challenging. The other thing I will highlight was that getting the simulation-based education approach incorporated into curriculum. Like we had previously curricula where it was mainly, back then it was content-based, then we shifted to modular-based, but then we didn't have that aspect of that approach of simulation-based education. So that was also aligning learning objectives with the teaching method was a challenging situation. We didn't have like at the beginning we didn't have policy or something that would back the decision of like buying from the decisions or the managers. So that was some of the challenge, like to have even budget for training, for buying equipment. But as we merged with the University of Rwanda, as we were growing with the investment of the Ministry of Health really supported the University of Rwanda, especially in the simulation. We get to have experts who came and support us, and now I'm shifting to how we came up to, maybe that will be another question, but I want to say how we came up with those challenges. We had the support of development partners, but also we have the support from the Ministry of Health. We have an understanding, a buying from our leaders from the University of Rwanda, and we get then trained people, like a core group of people who would understand. Like we first trained TOTs, and they helped us, really, they helped us. And the other thing I would say, we benefited from visiting, like a tour visiting from other universities around. We went to Kenya in the region, but also overseas to see how it works. So those are things that helped us to come up, or like to deal with the challenges that we had. Thank you.
Thank you very much. I believe most of the challenges she mentioned about faculty development, opportunities in simulation, as well as expensive equipment and even faculty buy-in to use simulation, they resonate to the majority of people in this room. So hopefully with this discussion, we'll find solution together. So my second question goes to Professor Mohamed. What key lessons have you and your colleagues learned from the development of Simulation Center across Morocco?
Thank you, Arlena. So first of all, I would like to address my heartfelt thanks to you, to Marvin, to the organizing committee. I didn't hesitate any time to attend this amazing conference, even after a very long trip, 14 hours of flight, even with the fasting days, but I think it worked, and it's time that we be able to work together between countries from across Africa. Regarding your question, actually, yes, we have we have a lot of key lessons from developing simulation center in Morocco that can be applicable to all Africa. I can maybe talk about 5 different things. Now, the first thing, it's about you have to deal with the context-specific simulation design. Why? Why I say that? Because we have to deal with the needs approach, a needs-based approach, because each region has its own challenges. For example, maternal mortality, trauma, infectious disease, and I think that simulation programs has to prioritize the most pressing of clinical issues. The second thing is about you have to respect the language and cultural differences. Your scenarios have to deal with cultural consideration, with language difference, and also with patient expectation. If you deal with this, scenario will enhance the learning impact on the learner. So the second thing is about having a sustainable institutional integration. You have, we have in Morocco, we work about implementing a simulation program into medical school and into nursery school, and our Ministry of Higher Education and Health have adopted this. So it's very important to embed the simulation program into national strategy health. It's very important, and by this way, you will be able to ensure a longer-term commitment from all the stakeholders. The second thing about this point is we try to have accreditation and recognition of our simulation program. Since the fact having accreditation ensure something like to secure funding for your simulation program. So we try to have a lot of affiliation, a lot of partnership from national society in Africa, but also around the world, and it's very, very important to have this support of national societies. The third thing is about having flexible and adaptive learning models. You can combine something like low fidelity models, task trainers, SP, and digital platform that we can create a cost-effective and scalable and affordable. And in Morocco, we try something I think very important that we can share with countries from Africa. So we go to people in the region with limited access to training. That we call the lab sim, mobile lab sim. So we have developed this aspect in Morocco, and trust me, it has a big result in region with limited access. That help reach remote healthcare worker without requiring them to come to the faculty of medicine or to school of nurses to have the training program. The most important thing, as the fourth one, is the faculty development and training the trainers. In Morocco, we have established a university degree. Yeah? Huh? Mike, okay, sorry. So in Morocco, we have established a university degree that we call University Degree of Pedagogy of Simulation and Pedagogical Innovation. And for young doctors who wish to become professor at the faculty, it's mandatory to have this degree. So in Morocco, right now, we are proud to say that we have more than 400 graduates by this university degree. And it's very important to develop this network and to develop the local experts who can cascade their knowledge and their experiences. One more thing is very important in Morocco that we can share with the countries from Africa is, I think we encourage the interprofessional training. Simulation is not only done for doctors. Simulation is for everyone. We manage people as a team, so we have to be trained as a team. So in our training in Morocco, mandatory, the most of our training is about interprofessional, so involving doctors, nurses, and ambulances for sometimes. And the last one, and not the least, the last one is you have to conduct a lot of scientific research and to prove that simulation is well working, to convince people to have funding like this. And something that I never understand why all the time as African people rely on products coming from other continents. They have brains, we have brains. And I think we are smarter. So we can think about creating our own models and our own mannequins. Thank you.
Thank you very much. That was so inspiring. Back to you, Dr. Marvin. So as the head of the African Simulation Network, what do you perceive as the key structural or operational barriers to designing simulation on the African continent?
Thank you for that question. I'm going to sound like a stuck record, but definitely number one would be faculty development. I think it cannot be overstated the importance of faculty development, because we need to understand that our most valuable resource are our people. So if we invest in our people, they will come up with innovative solutions that are tailor-made for our continent. So definitely number one would be faculty development. But there are other challenges that we also face. One of it, and Prof. Maui alluded to it, is a lack of national and regulatory support. I believe that if we start the process of our simulation curricula being endorsed by national policy and by our regulatory bodies, that would provide the impetus for it to grow, because it becomes mandatory then. Of course, saying that, we'd have to look at your national constraints and see how is it sustainable within your context. But definitely having that support will advance your program. So of course, what I'm saying is that the lack of national support is definitely a big barrier. We are aware that on the continent we have lots of infrastructure constraints, and we shouldn't underestimate the effect that that has on it. So in many parts of the continent, including South Africa, we don't always have reliable electricity, etc. But then I believe that that just really drives home the point that we need to think of low-tech solutions, and they can be as effective as high-tech solutions. So we really have to challenge the idea that we can only do effective simulation when we have the expensive mannequins that uses high technology. So some of the operational barriers, I think one of it is that I'm quite passionate about is oftentimes we have a silo mentality. And I'm not only speaking about within a country or within the continent, even within a university or within a program, we'll have a situation where one department has a mannequin, but another department also has a mannequin, but it's only being used one day here and one day there. So of course, we cannot have a situation where we are not sharing the limited resources that we have. And the only way that we can do that is from the onset, we need to be quite intentional about having the right stakeholders around the table when we're designing our curricula. So we need to realize that it's a valuable resource, and this resource should be shared within the universities, within hospitals, within the country, and definitely within the continent.
Thank you very much. To you, Dr. Rashmi, as someone coming from a private industry supporting simulation centers around the world, can you share Laredo Global Health's approach to support simulation programs in Africa?
Sure. Thank you so much for the question. I think LARAL, since its inception into simulation back in the 1960s, it's never been about the mannequins. It is more about being a means to reach an end. And what is the end? It is a health outcome. It is about helping save lives. So any mannequin for us is just a piece of plastic. Unless there is a man behind the machine, and the person who's learning from it is also able to learn from it effectively, then that piece of plastic is of no use. I think that's been the philosophy typically. And using the same philosophy, we've been working in Africa for quite some time, especially starting from Tanzania. And this has been the Safer Birds Bundle program, which was focusing mainly around the in-service simulation program, which started off with one hospital, scaled up to 30, and currently it is 150 hospitals. And some of them are also associated with medical colleges over there, like in Tanzania. But the point is that it was never about just the mannequin. It was about what was the need, finding out the need itself within these hospitals, understanding what would help them, so also equipping them with equipment, but not in the form of a large skills lab or something. So if I am working and if I have just 5 minutes for simulation, then how do I practice it in 5 minutes? So making it really easy for the providers to really learn. So we made that. And what we also learned was to make it sustainable, you need faculty within these places. So we actually developed the faculty through the SimBegin training programs. And so much so that the simulation doesn't need to be driven externally anymore. It gets driven internally. And to also help them run the simulations well, we also included a component of quality improvement. So 2 things. So quality improvement in training and quality improvement in the hospital. So if I trained, let's say on newborn resuscitation today, how did I perform? Okay, in a training scenario. And also help them get the same kind of an information from a hospital scenario. How did they really perform over there? And then that goes into, that talks to each other kind of a thing, through simulation programs, which we helped build. And finally, last but not the least, is equipping them with the actual equipment that is really required on the hospital side, because just the training is itself not going to be enough. You also need to be equipped to really do this. And as a part of that, in these 30 hospitals, in the National England Journal of Medicine, it was just published 2 weeks ago, where the hard copy was released. The maternal deaths were reduced by 75%, and neonatal deaths by 40% in 30 hospitals. And I think that has been the philosophy for us. And based off that, like, so Laral now, with the WHO, is going to be supporting in 5 countries in Africa to help train 50,000 healthcare workers. Now, this could be both pre-service, in-service, and so that it helps save 50,000 more lives. So that's pretty much been, and there's been a lot of other programs that has been happening around midwifery, around nurse education in African continent. And I think the red thread that actually runs through all of this is simulation, faculty development, quality improvement, because at the end of the day, it's never been about the equipment. It's always been about the man behind the machine.
Thank you very much. So I'm sure many people will be interested to know more about Laredo Global Health project that you're supporting, so they can come to you after. So Professor Mohammed, yeah, we keep hearing cost as a barrier to entry, to especially to new simulation, even to existing one. Can you tell us how you are doing in Morocco to keep the cost down and allow scalability into your simulation programs?
Okay. So, as everyone in this room, as my colleague, we all know that simulation is a technique, not a technology, as Gaba said. So we are more talking about a pedagogical approach rather than equipment, rather than high expensive mannequins. In Morocco, yes, we had this concern about cost-effective mannequin, but at the first stage. Because at the first stage, I'm talking about 2010, when we start simulation in Morocco, we thought as everyone as his first stage in simulation, we thought that simulation equal mannequins. But simulation equal pedagogical approach. And since we understand this, we start working about how to decrease the amount of equipment that we will be using in simulation. We started by using using less and less mannequin, but we use more and more SP, standardization. SP plus task training that we call hybrid simulation. We start also to develop the concept of telesimulation. So telesimulation is about using a platform of video conference, and we are able to run simulation just on a classical platform like Google Meet, like Zoom. And trust me, we have conducted a lot of scientific research, and it proved that telesimulation is work as well as simulation in hands-on. The third thing we were working about in Morocco is we are working about cross-institutional equipment. If we have a simulator for surgery of the eye, if I have a simulation in Casablanca, okay, Rabat don't need to buy one because it's closer. So if we have a very expensive simulator in one city, everyone can go to this city and use the simulator. One more thing that we try to develop in Morocco is the concept of the one-room school of simulation. What does it mean? Instead of having a large spaces for simulation, one medical simulation center, we can have just 1, 2, or at maximum 3 rooms, but they are flexible. We don't have mandatory to put this room is mandatory for pediatric, this room for sure. No. Each room is flexible, and with this manner to do, we have a lot of medical simulation center in Morocco. Last thing, we have a good partners in Morocco. I'm talking about commercial one. Because in Morocco, a lot of medical schools are opening. We don't have enough physicians in Morocco, so we are trying to have a lot of medical students. So partners are helping us to implement and to develop simulation across cities in Morocco. But the most important beyond of this, I think each country in all Africa must have this own national society of simulation. I'm very convinced that having a national society helps a lot development and integration simulation into curricula. I'm not sure about Africa, but I think in Morocco we have one, in Tunisia, in South Africa we have the network. I hope next year every country in Africa has its own national society. In Morocco we just published 2 weeks before national guidelines with the best practice of simulation in healthcare. I would like to share with you next year. Thank you very much.
Thank you very much all for sharing your great insight into simulation center development and faculty development. So it's clear that we need a concise way of training our faculty, but also integrating our curriculum within the national strategy, but also adapt it according to the local context. And Professor Mohamed, as Dr. Jansen mentioned, we need simulation network. So in Rwanda, we're also collaborating with the University of Rwanda and the other universities that do simulation to create the Rwanda Simulation Network. So stay tuned for more. Yeah, it's time for it. Thank you very much for your kind attention. And now I'd like to invite my colleagues, Dr. Callahan, back to the stage to moderate the second panel. Thank you very much.
Thank you, Dr. Masimbi. Wow, that was wonderful, and it's like we planted that Rwanda Simulation Society recommendation, Dr. Mohamed. So now it's my pleasure to introduce our panelists for the second session. I apologize that they're trying to get us back on time, so we're trying to move through this a little faster than we had anticipated. But so our first panelist is Nkechi Oluwakemi Dike. If you want to come join me. Nkechi is an emergency medicine specialist and senior lecturer at the University of Cape Coast School of Medical Sciences in Ghana. So please welcome her. Our second panelist is Dr. Tom Weiser. Dr. Weiser is the program director of SAVE Welcome Leap and a clinical professor of surgery from Stanford. I think our third panelist may not be here, but if you are here, Dr. Pennycook, are you with us? All right, I think there's just going to be 3 of us. Okay, so our final panelist and initial speaker is Dr. Michael Moneypenny. Dr. Moneypenny is the regional director for East Africa of the Center for Innovation in Medical Education at Aga Khan University in Kenya. Welcome. So I'm actually going to turn the lectern over to Dr. Moneypenny to give his introductory remarks.
Thanks so much. Thanks very much for having me along. I appreciate the invitation, the University of Global Health Equity and the organizing committee. We're having a bit of musical chairs along here. This is good. So I was asked to give a little talk on low-cost, high-impact simulation and return on investment. Should there be some slides at some stage? There we go. So when I was based in Scotland, I used to go around various places because they were asking me to help them out with doing some simulation and simulation-based learning. This wasn't the suitcase I had with me, but I ended up in prisons, not as a prisoner myself, but because they were wanting to know how they could improve the healthcare that they were giving prisoners. I'm not sure if Liz Grant is in the room, so I don't want to paint too bleak a picture of Scottish prisons, but they can be pretty rough places, often actually self-harm, sometimes being harmed by another prisoner. And as the prison population aged, also cardiac arrests, and as they got comorbidities, also diabetic ketoacidosis, etc. Anyway, I was in one of these prisons and I was chatting with them in their staff room, and I was saying to them, well, what have they done so far in terms of simulation? And they had said not very much. And I said, what was the challenges that they were needing to overcome? And they said one of their biggest challenges was that they didn't have any equipment really for simulation. So as my colleagues in the previous panel had talked about, I said it's not really so much about the equipment, it's more about what you're trying to do. And we were talking away, having a cup of tea, and then I looked up and I saw this suitcase up on the shelf, which looked like it hadn't been touched for a while. It was covered in dust. And I said, "What's in the suitcase?" And they said, "We don't know." I said, "Why don't we have a look?" And we opened it, and I know there's somebody from Lairdal in the room, but actually it was one of the original Lairdal mannequins was in this suitcase, probably worth an absolute fortune. So we got the mannequin out, and we had a little bit of a chat about what they could do with it, etc. But one of the things I took away, and I'd like you to take away, is work with what you have. It may be that you have something stuck in a cupboard somewhere, and in fact, the more spaces I go to, the various hospitals I go to, someone somewhere at some stage has probably bought something and stuck it in a cupboard, and you just need to go and discover it. This is another little story. So this was a few weeks ago, and I was having a chat with a colleague, and chat is probably not the right word because this is what the colleague was looking like, maybe not quite as angry. And we were talking about the use of simulators and what was required. And they were saying that they were going to go right to the top because they wanted this really, really expensive simulator, and I wasn't getting it for them. They were going to go right to the top. And I was thinking, well, unless the people at the very top have also got a money tree, because the simulators we're looking at were somewhere between $60,000 and $120,000, there wasn't going to be much use. And again, the thought for me here, as the previous panel was saying, it's not about the stuff, it's about the people. I know Marvin was talking about faculty development. So again, be robust. And I know we can't walk around here without stumbling over a dean of a medical school. So please don't go back and say Michael Moneypenny said we're not allowed to spend any money on you guys. There is some money required, but often the most expensive pieces of equipment will lie there untouched or only touched maybe one day a week if you're lucky. So again, have a think about what's really required. This is Six Sigma. Six Sigma, which many of you maybe know, is a concept, a improvement methodology from industry. It also, people talk about it in healthcare or Lean Six Sigma sometimes. And basically what it says is that with Six Sigma, if you've reached the heady heights of Six Sigma, you have about 3.5 defects per million units. Unfortunately, that's not true in healthcare, unfortunately, at the moment. Although, and I know there's a few anesthetists in the room, we're not that far away in anesthesia. Especially in high-income countries, the risk of dying due to the anesthetic, I'm not saying what happens with surgery, but due to the anesthetic is about 1 in 100,000. So we're close to Six Sigma, but one of the problems we have in simulation is sometimes we look at the things that people are doing already. So often, especially in the place in the UK where I've just come from, a lot of anesthetists are involved in simulation. And so we do a lot of anesthetic simulation, which is a little bit counterintuitive because anesthesia is relatively safe already. So one of the things to think about in your context is, where's the harm in your context? Where are people dying? Where are people being harmed? And then that's probably where you should focus your attention. Simulation may be the answer or maybe part of the answer, but certainly that's something that we need to think about in terms of simulation as well. This is a blank slide. And the organizer was saying, are you sure this is your slide? I said, yeah, it's blank. This is safety. Safety, as Sidney Dekker says, safety is a dynamic non-event. The person who didn't die, the patient who didn't come to harm, the child that went home. And so it can be difficult to measure in terms of return on investment. But certainly in terms of time spent, I would suggest that simulation is one of the most highest return on investments that you can have. I was thinking about a story about someone was saying that they knew somebody who was a fantastic Olympic level swimmer, amazing swimmer. They said, how do you know? They've gone to all the lectures, they've read all the books. And we know that's not true in healthcare either. It's the application of knowledge that matters. And again, I would suggest that in terms of return on investment, spending time in a simulation lab returns that to you multifold. So I've come to the end. The things, again, my give home messages are work with what you have already, make sure you focus on technique, not technology, and look and see where the harm is happening, and then you'll get your return on investment. Thank you very much for listening.
Thank you, Dr. Moneypenny. That was great. A lot of wisdom on these simulation panels that I've found. So I'm going to start with you, Dr. Duque. So you spend a lot of time advocating for increased adoption of simulation education at your institution and beyond. And so I'm curious, what are some of the key points that you find really resonate most with stakeholders and policymakers about the value of simulation?
Thank you so much for the invite to the committee and to you as well. I think what I've found that resonated the most with stakeholders is typically storytelling. Ironically, that's actually what it's telling a story from stakeholders, the end user point of view. So let me back up a little bit. I will approach that question in terms for anyone who's trying to advocate for simulation in a new space, like I found myself a couple of years ago, over 9 years ago, was to say, think about the contacts that you need and the context. So two things, the contact and the context. Now the contact, I made it as simple so that you can remember. I like alliteration, so contact. And thinking about the contact are your stakeholders. Who are your stakeholders? It's typical to think that, okay, it's the leaders. I would start by saying at the most basic level, I am the first stakeholder. And so that was my story. I was a typical end user needer, the person who needed simulation the most as a medical student, right? So I had poor eye-hand coordination and I didn't even know. I was brilliant. However, I find that I have to do procedures way longer than other people. Of course, when I did it several times, I will get it and you can't take that skill away from me. And then fast forward that into working for the military and I saw how much simulation went into the military. I began to think way before I became an educator or faculty that are there other things that we could use this for in medicine? And so way fast forwarding that again, I find myself in emergency medicine and also now the head of a clinical skills lab, right? So here I was thinking to myself, what do I do? You know, now I'm in the position to train students for, you know, with clinical skills. And then in emergency medicine, I see the sickest of the sickest. I began to ask the same question. Why should the first time I pass a chest tube be on the patient who is dying? And so all of these things began to resonate with my passion for road safety, for injury prevention, and things like that. So all of that culminated in me saying, I was the first person who needed simulation. I was my first stakeholder, like an end user. And I was so on fire at the risk of not even being recognized. It was so futuristic at the time I first presented this to the College of Physicians and Surgeons 9 years ago. They told me I was reinventing the wheel. But at the risk of that, I was on fire. You couldn't take that away from me. I became so vocal about it because I could see the results and I knew what exactly, you know, it would bring. And so fast forward to that, going to do my fellowship in Mayo Clinic, Florida, in simulation, I realized that we're really onto something and we're missing something. So on returning, I couldn't stay. Even with all the offers to stay, I couldn't stay. And so returning back to Africa, I had to tell myself, it's either you're a lone wolf and you're going to speak for this in Ghana. And so I was so on fire that I was my own first story. And so when I began to tell that story, and then trying simulation, training, you know, residents or doctors, one particular one stuck out to me was someone I taught at Crike, using some trachea, like animal trachea, and 48 hours later needed that same procedure to save a life. 48 hours later, the difference between life and death, if we're talking about equity, is a remediable and avoidable skill difference. And so I began to advocate that, equity isn't just about, access or socioeconomic factors. It was actually the skill of the first person you present to. And I have had family members lost, because somebody couldn't pass a chest tube when they needed it. So this was first me and my own experience and my own losses that drove that. And when I tell that story, it really resonates. That's what I meant by, so first I was my stakeholder, and that continued from that. I found my allies. And so for anyone looking to, bring simulation into a space, find your ally. I want to give a shout out to my dean, he's somewhere in the audience, because it was my first ally 5-6 years ago, promised me that I will make this central in my tenure, and he's kept to his word. And so when I found that ally, I was able to scale that into faculty buy-in. Right? So all of my work for the past 6-7 years had just been faculty sensitization, just saying, this is what you can do, and these are the stories, and these are the piloted results. And so that's the contact. Once you find that, and you can do that, you know that you have your contact, but the context also matters, and I will land on this point. The context is that the answer and all the reasons why we should do simulation has been clear today. We've talked about that today. However, I found that the story was different. I knew that I couldn't come back from, a very high end where all the resources were to come into Ghana and saying I wanted to be altruistic and change the system. So I needed to understand the context. When I'm speaking to a university, what I'm advocating for and what they need is different from when I'm speaking to a college of physicians where they train residents, and their need at the time will be different, and I'll give the example. And then finally, if I'm speaking to a hospital, their need is also different. So contextualizing the need and saying, what does simulation solve today? The problem of that leader. So for the medical school, COVID amplified that for us. Our students couldn't see patients, we couldn't expose them to patients, and so it literally threw us into a panic, and we had to start saying, the future that you thought was so far away is now here. And so that really, really sold the case for simulation for the medical school, coupled with the fact that we could scale up training. Students in our schools used to be 50, and now they're over 100. So we could use simulation to scale that up. And so that was one of the key things that drove the message home. And of course, we got, a high-end simulation things right now. For the College of Physicians, it was competence. So when I'm selling it, one is competence-based. They want doctors who can see cases, who can manage cases. As a resident, you might go through all of your training and you will not see a particular case, particularly rare scenarios. And the first day you become independent, you see that same case. And we saw it over and over again. And now the conversation is moving on to that. And finally, for the hospital setting, what sold it for them was quality. They're looking at maternal mortalities, they're looking at neonatal mortalities, they're looking at their morbidity results, and they're saying, we need to do some in-service training. And so that sold simulation across 3 different spectrums, for the university, for postgraduate college, and also for hospitals. I hope that summarized that for you perfectly. Thank you.
That was amazing. I think I found a new best friend in simulation. I'm going to be calling you after the conference, and we're going to come up with a policy agenda, I think. I think I can really resonate with what you said, because one of the reasons that I became very passionate about simulation was that I felt like I learned really well through simulation, and I think you probably would find that a lot, among simulation educators. So I want to turn over to Dr. Weiser. So you are the program director for SAVE from Welcome Leap, and I was hoping you could tell us a little bit about the mission of SAVE, the SAVE program, and how you think it could be used as a model for change in other disciplines as well.
Certainly. So SAVE is Surgery, Assess, Validate, Expand. It's one of a portfolio of programs for the Welcome Leap philanthropy. And Welcome Leap is essentially an advanced research projects agency for global health. So the concept behind Welcome Leap as a funder who is looking for novel breakthroughs is it identifies a problem, a major white space in global health that hasn't been solved through traditional mechanisms. And then it hires a program director like me and helps identify some problem at the intersection of health and technology that I believe it can solve with a concentrated, organized effort. So the difference is that as a funder, we don't actually give grants. What we do is we provide activities-based funding, meaning that we coordinate a group of actors across a host of disciplines to address a problem in a coordinated fashion, which is very different from kind of your typical grant making program. So the SAVE program, when I took it on, one of the, as we've been talking here at this conference, one of the fundamental problems in surgery is a fundamental lack of surgeons. And the problem is a pipeline problem. The problem is one of the legacy that we have in medical education. And it's one of a poor mechanism for accelerating skill acquisition and an incapacity to really objectively measure competence and proficiency. And so, and this is a problem I would note globally. So in the United States, we're going to be 16 to 30,000 surgeons short within the next 10 years. So this is a problem really of degree, not of geography. And so we have to think differently about one of the ways that we're looking at in SAVE is how do we think differently around educating and accelerating the skill acquisition, in particular for surgeons. That's the program that I run. And so I'll make a shameless plug for our panel tomorrow, AI in medical education and assessment, where I'll talk about some of the breakthroughs that we've been able to accomplish in a very short period of time. And one of the key concepts, and it's been discussed here a bit, including by Dr. Moneypenny here, about the concept of actually bringing education to the learner where the learner is. And one of the ways that we believe we can do that is by changing the way we think about how we educate people. We want to educate people in their homes. We want to educate people on the wards. We want to give people that 5 minutes of time to actually do something useful, get objective, qualified, and quantifiable feedback that then enables them to enhance their performance. And so we're doing that through a number of different techniques, but some of them are simple things like gaming techniques, right? Being able to create an enjoyable and entertaining type of environment for learners to actually acquire skills, get feedback, and then do their reps. And nobody wants to do their reps on things that are boring, that don't make sense, that don't seem to have tangible benefits. But when they start being compelling, when they start being interactive, and when you get the kind of feedback, when they become competitive, where you can be competitive with yourself and with others, then you start actually getting an advance and you come back for more of your reps, so to speak. So that's what we're focusing on. The other part of the SAVE program, which I won't talk about, is as we think about accelerating skill acquisition, objective measures of competence, increasing the workforce, we also have to make sure that there's safety on the other side. So the corollary to the increasing the number of providers is at the same time we want to reduce postoperative mortality by 50% or more through improved monitoring and evaluation. So those two things go hand in hand to that point of safety that as we build our provider base, we also need to reassure our patients and our population that we're delivering the best possible care for them.
Thank you. I think that's a really good point, and I think it's very pertinent right now in Rwanda with the 4x4 initiative and trying to make sure that we can sort of fulfill that need without sacrificing quality as well. Dr. Moneypenny, I was hoping you could talk a little bit about, and maybe with some examples or details around what success looks like for you guys at Aga Khan in the simulation center, and how you're thinking about return on investment or evaluation in your simulation scenarios.
Thanks, Chris. Can you hear me okay? Thanks. I suppose if you think of two hospitals, and in one hospital, a patient dies due to medical, in inverted commas, error, and they have a hot debrief, they have a cold debrief, they look at contributing factors, and then they put systems into place to try and stop that from happening again. So that's hospital one. Hospital two, there's a near miss. A patient almost dies. They have a root cause analysis. The culprit is identified and fired. And you have to go to a hospital to have an elective procedure done. And I wonder which hospital would you choose to go to out of those two? The one where the patient died or the one where the patient almost died? And that's a rhetorical question, because I would suggest you go to the one where the patient died. Because one of the things that we've alluded to a little bit is the use of simulation for system safety. So simulation, you saw it being used here as a demonstration. Many people think of simulation, they think of basic life support, chest compressions, and they think of maybe a simulation center. And again, that's where cost comes in. People think you have to have a multi-million-dollar simulation center. But actually, what we need more of is simulation in the workplace. People call it point-of-care simulation or in-situ simulation. Because if you end up just doing 1 day a year, let's say, which people often do, an airway workshop, or some kind of ACLS or something like that, we all know that with skill decay, after the year, your skills are decayed. So what you need, and what we need, is more simulation in the workplace, in the hospitals, in the clinics, etc. So success for me would be that, yes, we continue to do high-quality simulation in a simulation center for various beneficial reasons, but it's also used in the hospital to look at systems. So I'm very interested in optimizing both human well-being, but also system performance. And I think that's what success is for me, because then you can look at return on investment in terms of time to needle for people having strokes, for example. In my previous role, we reduced the time to neonatal intubation from minutes to seconds in a neonatal intensive care unit, purely by doing repeated simulations in the unit to see what can we do to improve the system. So we weren't improving, the team was the same team, and they were no better trained in inverted commas, but we put processes and procedures and equipment into place, which meant that we actually almost certainly saved a number of neonatal lives. Thanks, Chris.
Thank you so much. So, so we got our 2-minute warning up here. So we're gonna pause on any more questions. You guys, thank you so much. I wish I could ask you all the questions I had prepared. But I'm gonna just leave everyone with some closing remarks, I think, for the whole session around simulation as a whole. So first, I just want to thank all of our amazing panel experts for being here today and sharing their wisdom and experience with us. So if you could just give them all one more round of applause. You guys can stay here. So I think, a few reflections. None of us obviously would be part of this session today if we weren't incredibly passionate about pushing the boundaries of medical education in learner-centered approaches that ultimately, hopefully, benefit our patients. And as I said previously, I think we can all agree that simulation plays a key role in bringing our patients to life in psychologically safe environments where learners can refine their practical skills and knowledge scripts without the consequences of human life. And I think, however, there's many challenges and barriers to scaling this type of technology and pedagogy that we still face, and you've heard a lot about that from our speakers over the last 45 minutes. But I just want to leave you with a few key considerations that I hope you take away from this session. So the first is, as was mentioned during this morning's opening, strong educational programs start with well-trained, passionate faculty. And I think simulation is no exception, and we must work together to share resources in order to invest in the training of more medical educators in simulation-based education. I think second, we must also work together to figure out what success looks like in simulation. Medicine is one of the only high-stakes professions that doesn't have regulatory requirements to regularly practice before encountering scenarios in real life. And how can we ensure that maximizing the potential of simulation, not just subjectively improves the learning experience and learning transfer for students, but that it actually affects curricular design that leads to improved patient outcomes? Third, simulation centers can be expensive. You've heard this a lot. But simulation programs, and Dr. Jensen sort of hammered this home, can start absolutely anywhere. So don't wait until you have full funding for a sim center to begin a program at your institution. Anything can be used as a patient, and with the right faculty and a set of guardrails for the students and stage setting, the only barriers to the first simulation session you're going to run are time and a lack of imagination. Okay, so please just start. And lastly, we also need to humbly recognize that simulation as we know it today may be completely transformed in the next 10 years. Technology is changing very rapidly, and we need to find ways to leverage extended virtual reality in concert with other digital technologies in order to think about how we're going to decentralize and democratize simulation going forward. So thank you again for attending today's plenary session. We're so glad you're here with us today, and thanks for your time. All right, so I think there's actually a refreshment break that goes for maybe 10 more minutes, and then the next session is supposed to start at 4 p.m.